Hello, everyone. Thank you all for joining us for our March Research Spotlight webinar. I'm Dr. Sarah Hernandez, the Director of Research Programs at the Hereditary Disease Foundation. I want to start by thanking our sponsor for this webinar, which is Ionis Pharmaceuticals, as well as everyone who supports the HDF. It is truly because of you that we are able to fund exciting science that is transforming what we know about Huntington's disease. And a big thanks to all of you for tuning in. Thanks so much for joining us today. Today, we are hearing from someone who doesn't specifically study Huntington's disease, but she does study something that is super important, not only for every single person with HD, but for every single person in general. And that is how we can keep our brains healthy to prevent and delay dementia. We are joined today by Dr. Gill Livingston. Dr. Livingston focuses on intervention to help people with dementia and their families. She leads the Lancet Standing Commission on Dementia Prevention, Intervention, and Care. And this commission studies potentially modifiable risks in dementia and gives specific recommendations about what people and policymakers can do. And this has impacted policy as well as driven research and increased awareness. She works to the commission's tagline, which reads, "Acting now on dementia prevention, intervention, and care will vastly improve living and dying for individuals with dementia and their families, and in doing so, will transform the future of society." Thank you so much for joining us today to share your work. Before I pass it over to you, Jill, I want to remind everyone that you can ask questions in the Q&A box throughout the talk. So try to remember to use the Q&A box, not the chat box. We should have about 20 minutes at the end for a Q&A, so type your questions in as you think of them so that you don't forget, and we'll address as many as we can. Also, a reminder that this will be recorded and available both on our website and our YouTube channel in about 2 weeks. So if you want to watch it again, or if you want to share it with someone that you think could benefit from this webinar, it will be available for you to do that. Thank you, everyone, again for joining us, and I will pass it over to Jill.
Okay, thank you very much for inviting me to talk to you. I'm talking to you from London, where it's a dull day, which is not totally unusual. And I'm going to talk about some of the work that we have done in the Lancet Commission and tips for preventing and delaying dementia. And this is relevant, I think, to everyone, but I also want to talk a little bit about how it might have particular relevance to the Huntington's community. So first of all, I just want to say that this is not just my work, but has been done by many people from around the world. And here's a list of them all. And we all worked really very hard together to do this work and put together the evidence and to make new evidence. So what I'm going to talk about is a bit about genes and environment, and then a bit about brain reserve, dementia risks and what it means and what we should do. So what is dementia? Dementia is the most feared disease of older people in the US and the UK. And I think we probably understand why people might fear dementia, because of dependency and the loss of the memories of who they are, their families are, their history together. And Huntington's disease, as you very well know, is a rare cause of dementia, as well as having other symptoms. The number of people with dementia is currently over 50 million. But it's because we have an aging society, as fortunately fewer people die young, is expected to rise to 132 million by 2050. And it's important and has been relatively neglected previously, regarded as neither preventable or treatable, but things have changed. And it affects, like Huntington's, the person with it, family members who look after it, and look after the person with Huntington's or dementia, and it affects society because it's often far too much for one person to manage by themselves. So society often has to step in and help care. Now, most dementias are not caused by an autosomal dominant gene, although some are, but Huntington's disease is, of course, entirely genetic. There's been a huge amount of research going on. But I'd like to think about Alzheimer's disease for a minute, where we've really not been able to change genetics. I'm going to say a bit more about this, or the protein deposition in the brain, but we've had a huge change in Alzheimer's disease incidence, and that is the number of people per any age group. So it's been a reduction of about a quarter per 100,000 in several countries, including the States. And the difference is brain resilience and also change in vascular damage. And I want you to think about the idea that in Alzheimer's, even people who have genes related to it, if they engage in this or if they are able to live the sort of life that we think is good for your brain, that while they may develop dementia, they may have many more years of where they are well. So now we have a reduction in age-specific dementia in many countries, in the States, in Europe, in Britain, and that's been a 25% in age-related incidents in 20 years. There are still more people with dementia as there are more older people, but there are fewer people per 100,000. And in the high-income countries, it's only those with more education or wealth, and it's been men more than women. So there's still a huge potential for other people not in these categories to begin to improve. But it shows it can be done, as well as there's potential to do more. And again, I'm going to talk a bit about the mechanisms. So this is a study in the Lancet, nothing to do with me, but if you look at these graphs at the bottom, they show that people with more neuropathology are on average more likely to have dementia. So these people, these are post-mortem looking at neuropathology, and if you look at the bottom left-hand corner, those people with a high performance cognitively have little neuropathology, and those people on average with late dementia have twice as much neuropathology. But if we look at the different graphs, each of these lines is one person, you can see there are people with a high cognitive performance, if you look at the top left, who have quite a lot of neuropathology, and some of them have more neuropathology than some people who have late dementia. So some people who have neuropathology, who have the plaques or tangles or Lewy body, or even the vascular brain injury, do not have dementia. And the question is why? What is it that helps them? And what this is we talk about is cognitive or brain reserve or resilience. So people who have healthy lifestyles have a brain which can cope with more neuropathology, and dementia onset is delayed, and their life expectancy is longer, but dementia onset is delayed for more years than their increased life expectancy. So they have more healthy years and fewer years of illness, which I think is what we all want. And that's what we call a compaction of morbidity. So as I said, the Grodstein paper in 2023 showed that if you look at in the States, over the years, people in general have no less plaques and tangles, which are the pathology of Alzheimer's disease. These are the abnormalities in brain in Alzheimer's disease, but they still are less likely to have dementia, which is the symptoms, the things that people don't want to do. And that is because of two things, that they have less vascular damage and they have a more resilient brain. So keep that in mind. This is what we're looking for. Resilient brain. Cures would be good too, but it's not necessarily on the horizon. So what helps and how do we know? Well, that's what we tried to do in the Lancet Commission. And a group of us meet, and before we meet, we review, different people review different evidence. We then present it, and we decide to include as risk factors something which has consistent high quality studies which show a dose respondent. So the more you have a problem, the more likely you are to develop dementia. Validly measured problem. It's biologically plausible. We can understand what might be happening in the brain. And the problem isn't when people have dementia, but before the dementia, it remains more than 10 years before dementia, and that changing it makes a difference. So we looked at the existing evidence, we searched the existing evidence, we prioritized systematic reviews, which are looking at all the evidence to try and make a decision. We had expert input from different countries and disciplines so that we could see different points of view, different knowledge. And when we had to, we ourselves did some of the original research to increase our knowledge. So one of the things, or some of the things that might have made a difference is that lifestyles have changed during all of our times. Many fewer people smoke than used to, and that's particularly true of younger people. People have more education than they used to, and that's vastly increased over the years. And there's been, in general, there's been a decrease in cholesterol with statins, a decrease in mortality, and a slight decrease in blood pressure, as people have had, not that they don't have high blood pressure, but as they have high blood pressure treated. What we tried to think about was a population attributable fraction. I don't want to go into it in any great deal of detail, but what I want to say is that's the amount that any risk factor matters if we look over the population, and it's to do with two things. It's to do with what difference any risk factor makes and how many people have it. And we looked at international data, but it does vary between countries because countries vary. We adjusted for communalities. People are not like lab rats. The person who has one risk factor is more likely to have another risk factor. So the person who doesn't exercise is more likely to be obese and more likely to have diabetes, more likely to have high blood pressure. These things are not, so we have to think about what it is, how they cluster together, and we came to a decision. So these show, I don't want you to look at it, but I just want you to have some idea that this is a transparent way of doing it. We've shown how we thought about all of these different risk factors and what we found and what whole number that came to. And then we put this all together, and with 14 risk factors, of which I will tell you a little bit more in a minute, we were able to say that 45%, these are 45% of dementia are potentially avoidable if you could change them all, which of course you couldn't change them all, but you might be able to change a great deal of them. And if you look, one of the ones which I think that we in general we're not really surprised now, but we were surprised at the beginning, that was the biggest, well, the one that is the biggest is hearing impairment in midlife. And that makes a massive difference. And that's followed by high cholesterol, and then by less education and social isolation. And we've done 3 of these. And the interesting thing is, even since three of these Lancet commissions, even over the time that we've done them, education, more people have been educated, and education is less important than it used to be. It's still very important for the individual. We think it's very important to make a brain resilient. So I'm going to talk about these risk factors and try and explain them. So globally, educational attainment has increased. It's still low in some countries. Most countries have some education. There's been, in the States, the reduction in dementia prevalence has been particularly in minority ethnic populations with improved education. So we can see that the education makes a difference in all populations. And more recently, we published a paper led by my colleague Mika Kivamaki, but I was one of the authors and various people, and we were able to have a very, very high number of people. And for the first time, we were able to think about some people who didn't have much education, but then had a highly cognitively stimulating work. So their work had a lot of brain exercise in it. And what we found, because before that we hadn't really been able to separate it out, because people with we weren't sure if it was just that people with more education did things that had jobs that required more brain stimulation. And what we found is that people who had education were about 70% as likely to develop dementia as those who didn't. But people who didn't have education but then had a highly stimulating job were still less likely, about 80% chance, compared to those who didn't have the education and didn't have a stimulating job. And for those people who had both the education and a stimulating job, they had about a 60% chance of developing dementia. And we were able to look, and these had American and British populations in these cohorts. And we were able to look at the proteins in the population and find that education was related to people having more proteins, which made the nerves in the brain repair themselves. So education is early life, but also in midlife, and that makes a difference. And cognitive stimulation in midlife continues to help. We don't know about late life, but it probably helps as well. And what we've by cognitive stimulation, I mean not just doing Sudoku, but to try and use different bits of your brain in different ways. So to do a varied and demanding occupations. Moving on to hearing loss, there are now quite a lot of studies which look at people with hearing loss, and some of these people wear hearing aids and some don't. And you will probably know from your lives, everyday life, that people, many people say that they can hear fine when their families think they can't. And people don't necessarily like to wear hearing aids. It takes a bit of time to adjust to them, and sometimes they find it stigmatizing. It makes them feel old, and they don't necessarily like to do them. But if we look at people who wear hearing aids compared to people who don't wear hearing aids, we find that the people who wear hearing aids are less lose their excess risk of dementia. That doesn't necessarily mean that it's caused by that, because maybe the people who use hearing aids are the people who have more money, people who are more likely to manage their lives well and look after themselves. But there was also a very interesting study which came in 2023 from Frank Lynn in Johns Hopkins in the state. And he did a randomized controlled trial of hearing aids over a period of 3 years for people who for people with lack of hearing, and found two things. He found there was a cohort of volunteers, and it didn't really make any difference. They were super healthy people. And also there was a cohort of people who were part of who were on a register and were known about for years. They were older and less well, and it made a vast difference for the people in the intervention group compared to the non-intervention group. So hearing aids seem to work if you were at risk of dementia. For the people who weren't at risk of dementia, they didn't develop any symptoms anyway over a period of 3 years. So that's the ACHIEVE study, and the ARIC population, which is a well-known United States population who were a bit older, were more likely to smoke, less educated, more often lived alone. They did very well and had and at the end of it, there was the cognitive decline was much higher in their group. So I think that shows that we need to treat high risk groups. The next thing I want to talk about is the next most common is cholesterol. Cholesterol is pretty easy to treat, and it's very, very common. About 2/3 of midlife people by late middle age have high cholesterol. And people who use statins in midlife and keep using them decrease their risk of both dementia and Alzheimer's disease. And that's a clear opportunity to prevent dementia relatively easily, relatively cheaply, and with a drug which for most people doesn't have many side effects. I'm going to talk on about depression. Midlife depression increases the risk of dementia. And we've only really just been able to, this is the first time we worked this out for the commission, that we were able to separate midlife depression from late life depression, because as people are developing dementia, they may be depressed. And the great news is that while midlife depression increased the risk of dementia, is that people who took antidepressants or had psychotherapy or both, or their depression got better, didn't have this increased risk of dementia. So if you or your family are depressed, I very much suggest that you have this treated both for your quality of life at the time and to decrease your risk of dementia over the long term. Moving on to high blood pressure. High blood pressure is something that there've been a lot of trials trying to treat people with high blood pressure. And what we find is that they're always abandoned because the people who have the treatment do so much better than the people who don't, that they have to give them up. And because of that, they've had to add them together. But the good news is that the people who have been treated have a decreased risk of dementia compared to those who don't, and a decreased risk of cognitive impairment. So smoking, you'll never find a doctor who suggests you don't smoke. You do smoke, rather. All doctors say don't smoke. So I say don't smoke. Try and stop. It leads to cardiovascular pathology and is directly toxic to your brain. But good news is it's declining in most countries, certainly in high-income countries. But the other good news, and perhaps unexpected news, is that people who stop smoking lose their excess risk of dementia over a period of a couple of years. So if you don't have dementia and you stop smoking, even if you smoke for many years, your brain recovers and you don't have an increased risk of smoking. So I want to move on to talk about traumatic brain injury. In high-income countries, it's mostly from falls or violence. And in low-income countries, it's mostly from road traffic accidents. And when I went to medical school, we thought that some people never recovered from traumatic brain injury, but if you did, it didn't really make any difference in the long run. But that's not true. People who have traumatic brain injuries, who are concussed, who are unconscious for a period of time, still have an increase in the likelihood of developing long-term dementia. So veterans in the United States who've had head injury in the army are much more likely to develop dementia. But the big news has been head injuries from sport. So rugby has the highest concussion rate, but probably not many of you been playing that, but that's followed by American football and then ice hockey. And in America, there's been a big campaign about not hitting your children on the head. And there's a lot that we can do to prevent traumatic brain injury. In Australia, they now have laws about not having tackling at a high level and not coming back on the field. Many football games and are not allowing children to have the ball near their head, and also to sit it out. There's huge amounts we can do apart from the continued increase in road traffic safety. Moving on to physical inactivity, exercise and fitness is certainly good for most things. And again, people who have do more exercise are less likely to develop dementia. But again, starting to exercise at any age seems to help. But it probably needs to be quite a long time, longer than a trial where it only lasts for 6 months or so. But the really good news is that the biggest change, you don't need to do marathons or ultra marathons. The really big change is going from being sedentary to just moving a bit. So if you're not moving very much, move a bit more. If you're moving a bit more, see if you can do some more. But exercise is good for you, good for your heart, your brain, but particularly good for your brain. So moving on to alcohol. I'm very sorry that I forgot to change this to American. Oh yeah, no, I've got it here. American drinks. So more than 14 American drinks, which is more than 21 units of in dementia a week, makes you more likely to develop dementia, more likely than people who drink less than 14 than these 14 drinks a week. Though not more likely than people who don't drink at all. Again, I don't think none of us have ever been surprised that heavy drinkers are more likely to develop dementia. But I think that what we didn't realize is that people having a relatively low amount of alcohol, so you can easily have that by having a large glass of wine a day, are putting their brains at risk. Again, with alcohol, like smoking, if you have not damaged and you stop for a couple of years, your brain recovers. Moving on to obesity. Obesity makes people more likely to develop dementia, but people who lose weight on purpose are more likely to do better cognitively. So again, a possible way of changing it. Less frequent social contacts associated with dementia. And if you think about it, the easiest way to get cognitive stimulation, to think more, is to talk to people. You don't know what they're going to say. You have to listen to them. You have to respond to them. So that makes a difference. And then moving on, sort of connected to obesity, is diabetes. Midlife diabetes is a particular risk for dementia. We're not so sure that late life is, but people who are now taking the GLP-1 receptor agonists for diabetes are less likely to develop dementia. We don't know with the people who are taking these drugs for obesity, but it's quite possible, are less likely to develop dementia. Air pollution increases the chance of dementia, but reversing it, such as in areas in China or in France or in Canada or in some of the US, decreased the risk of dementia. So it's very important to try and make the air cleaner, not to have more oil burnt within the air, and to think about residential wood and coal burning stoves. I'm going through lots and lots of them, but a really easy one is visual loss. It's common to have visual loss around the world, but probably less common in the States because it's mainly going to be treated. but untreated vision loss of any type is associated with increased dementia. It's higher in minority groups and in lower and middle income countries, and there's a higher risk with increasing vision loss. But many people, even in the States or in the UK where I live, don't really realise that they are developing cataracts and their vision is getting worse. People who have cataract extraction have no increased risk, and there's a clear opportunity for dementia prevention by treating vision loss. I'm just going to leave that one there. In Britain, there's now a policy that for the 5 years, every 5 years we have people aged over 45 are supposed to have a checkup, and the dementia risk reduction message should be communicated to everyone. And in the United States, you have a goal to reduce the burden of risk factors for dementia, aggressively addressing potential risk factors and decreasing it by 15% by 2030 and 15% every decade. So that's part of United States policy, and my understanding is that you have yearly checkups in the United States. So a huge possibility of looking at the medical as well as the non-medical factors. So I want you to think about what it means. There is new hopeful evidence about dementia prevention. Almost half the worldwide dementias are potentially preventable from tackling 14 risk factors. There has been a decrease for many, many people. There will be other risk factors, but evidence is unclear for some of them now. More resilient and less damaged brains help to delay the onset of symptoms. And we don't know, but it is likely that more resilient brains might also help in Huntington's, not in preventing the disease, but delaying the onset of the symptoms. There is much more evidence that interventions make a difference, that resilient brains work much better, and there's a potential for risk reduction. There's a potential to help individuals have more illness-free years, gifting what they want. What we all want is a healthy life and less years of unhealthy. So my thing, be ambitious about prevention. Think about you and your family's brains and what you can do to give you more years of disease-free life, or with less disease with life, more years of healthy life. These are, if you try and put all these things together, you can think about them as being cognitively, physically and socially active, not drinking or smoking not smoking at all, and not drinking too much, and keep looking after your health, keeping cholesterol, blood pressure down, your blood sugar under control, and weight under control. So thank you very much for your attention. I did see that there was some comments or questions in the chat. That's a picture of UCL where I come from, and I'm going to stop sharing my screen so that Sarah can talk.
Thanks so much, Jill. That's fantastic. And I think, anything that we can all do that's a very actionable item to keep us healthy longer, I think works not only for the general population, but also for people with Huntington's disease. So that's fantastic. It's great to have things that we can actually do. So we have a question here that you kind of addressed already, and they ask, if you're hard of hearing and you use a hearing aid, does that make a difference? And I think I would perhaps add to that, because you had mentioned treating these things, right? Like getting a hearing aid or treating high blood pressure, treating high cholesterol, those all do reduce your risk of dementia. But is there data to support that those effects are because the illness is being treated, or are there confounding variables that make that too hard to tease apart, right? Like if you are treating these things, you're more likely to be health conscious, or you're more likely to have health insurance in the US, which is very important, or you're more likely to be higher income. So can you really tease apart what effects are causing the dementia in that case?
Yes, I think you can. I agree with you. If we just look at naturalistic studies, then just as you say, it's people who look after themselves who use hearing aids. But if we look at the Baltimore randomized controlled trial, they call it the Achieve style by Frank Lin, it shows us something a bit different, because the people were randomized, so they were the same sorts of people. We're only able to follow up people for 3 years. The younger, healthier cohort didn't really make a difference, but the older, less healthier cohort, who are going to get worse faster, it made a huge difference. 45% difference in deterioration, and that's a massive difference, and probably isn't just the hearing. Probably what happens is that we're waiting for a bit more data, but that people who hear better, we know that if you can't hear, you tend to isolate, because you can't you can't work out what's going on socially, and it's humiliating and distressing. We know you're a lot more likely to get depressed, so people will go out, they'll be more active, they'll talk to more people, their mood will get better, and there'll be a sort of roll-on effect in all the other risk factors.
Thanks so much. So this kind of relates to that point you just made. There's a question that says, untreated vision or hearing loss, is this because they may lead to social isolation, or is it more than that? So that kind of leads into what you were saying. Could you talk a bit more about that?
Yes, it's very interesting. I think it's more than that. But yes, it's related to social isolation and brain stimulation. But what we know is that people who have untreated hearing loss, that they actually get shrinkage in the temporal lobe of their brain, which is the bit that's related to memory, and they have more deposition of the tau protein. So, I mean, I think we have to understand that everything that happens in the world around us is reflected in biological changes in the brain and the body. And what happens is that your brain begins to shrink and you have less resilience. And that's probably partly related to social isolation and low mood, as we were saying before. And it's all a bit connected with each other, but your brain shrinks. You can do an MRI and it's a bit smaller.
Interesting. So I guess this is kind of related to that. Someone asks, you talked about measuring proteins associated with education. Could you elaborate on this? It's fascinating that protein presence varies.
Yeah. So my colleague leads this, but I'm part of, we are very interested in what actually happens. You know, it's all very well saying people who are cognitively stimulated do better, but how does that work? We're very interested, and we are looking at cohorts. There's a few cohorts where we actually have their bloods were taken and frozen 20 or 30 years ago. And that's much more interesting, because if people have dementia and there's a change in their proteins, because that's how our body works. Our body mechanisms are done by proteins. Everything within our, when we think, proteins change in our brains and things. So this is and we weren't able to measure these things. People would spend their whole life looking at one protein and trying to measure it and find out that the answer was no, which must have been a bit frustrating. Now we can measure 700 in an hour and a half. So we begin to get, but it costs quite a lot of money. but beginning to get some answers. So everything, things begin to work through proteins and changes in their brain and our brain, and that suggests that we can change the environment, we can change what we do, but we might also give us more understanding of ways of using medication in the future to begin to change these things.
That's interesting. Here's a person that asked, did you look at sleep as a risk factor? And this is something we talk a lot about in HD research, so it'd be interesting to hear what you found.
We did look at sleep, and in fact I was at something last night and somebody said to me, do you know how much you've irritated all these people by not saying that sleep is a risk factor? I think that, yeah, but I don't do it on purpose. I'm just trying to look at the evidence. The thing about sleep is it's complicated. As people are developing dementia, their sleep gets worse. So there's no doubt that round about the time of people developing dementia, their sleep is disturbed for the few years before. But is that the dementia causing the sleep, or the sleep causing the dementia? Myself and my team, we did a systematic review, which we published a few months ago. And looking at all the studies, we found that if you looked at short sleep over 10 years before dementia, then it didn't seem to predict dementia. But if you looked at it, so that was before people were developing it, but if you looked at it a few years before, then it did. And we think that's what we call reverse causation. The dementia was causing it. But interestingly, and I'm showing that I don't think it's the whole story, there was a real difference between lots of the studies, and we tried to look in a mathematical way at finding what the difference was, and everything we looked at didn't account for the difference. And now we're doing some further studies looking how sleep interacts with other things, and I think it's we have some results, but we're going to be writing them up over the next few months. I think sleep is very complicated, but I do think that just by itself, having short sleep does not mean that you're going to develop dementia. I don't think it's a risk by itself.
How many hours, when you say short sleep, how many hours are you talking about?
Less than 6.
Okay. Yeah, someone with
and I want to say that I mean, I wear a Fitbit thing that measures that, but we're talking about people's report of sleep, because your Fitbit decreases about it subtracts about an hour when it says you had micro moments when you were awake that you're not aware of. But we're actually talking about if you go to bed, if you go to bed at 11 and between 11 and 5, so less than 6 hours is short sleep.
Okay. Here's another question about different variables. So are there data on the effect of chronic stress on dementia?
There's some data. It's very, very difficult because, excuse me, because what is chronic stress, and it seems quite likely that it's bad for you. We know that depression means that people, which is a result often of chronic stress, means that people are more likely to develop dementia if it's not helped. And it's and we know that anxiety in the presence of depression is bad for you, makes you more likely, but we're not sure that anxiety by itself does. So I think it's very difficult to disentangle what exactly what is chronic stress. It's certainly not very good for you, and it's not very pleasant, but I think the jury is out at the moment about what it does for dementia.
Thanks. There's a few questions here that I think I'll combine, and they're asking if there's a way to reduce dementia once it's already started. So if there's already signs of dementia, does using a hearing aid, can that actually help slow progression of dementia, or is it kind of too late at that point?
We think the preliminary evidence, and it's continuing, is that people with mild cognitive impairment, which is when your memory begins to be impaired, but it's not at the extent that means you need help in daily functioning. Which is sort of risk for dementia. It's a pre-dementia state. That wearing a hearing aid at that point makes a difference, and also tackling all the other risk factors at that point make a difference. We're not so sure by the time you develop dementia. It's obviously good for your health to look after your health generally, but we're not so sure that tackling the risk factors then makes a difference.
Here's one on genetic forms of dementia versus non-genetic forms. So they say, setting aside the purely genetic forms of dementia, if someone takes care of all the risk factors you mentioned, are they still at a small risk for dementia? Said another way, have you seen cases of dementia that can't be explained by the risk factors, including purely genetic?
Yeah, so even if everybody does everything, some people will still develop dementia. What we know, looking at the evidence, is that even people with the genes that predispose it get many more years of a good life. So I think that and that's where I think it becomes quite relevant to Huntington's, that some people will still develop dementia, and we are, not everybody agrees, but I think we're all going to die. We're all going to die of some things, So I think that the best that we can do, as short of taking our children's blood every 20 minutes or so, is to try and have as many good years in as short a time where we are really ill. And that, so even if you have the genes, we know it makes as much or more difference to the amount of healthy years you have.
Isn't the opposite also true, though? I was talking to a neuropathologist one time, and he said he's seen one control brain in his entire life. Like, there's not a brain out there that doesn't have some sort of pathology, but that person might not develop dementia. So isn't the converse also?
Yeah, in one of the slides that I showed you, the people who had the people who had high cognition when they died had some form of damage, and you know, as we get older, things happen to us. Things happen, you know, to your muscles and your skin. Damage happens, but in a way, most people don't much care about if there's some pathology in their brain. What they care about is if they have symptoms. You know, I'll take having a high cognition till I die and some stuff in my brain that I don't know about. That'll do me fine.
I agree. I totally agree. Here's a question that asks if you think these risk factors are the same for people with early onset dementia, not necessarily HD, but say early Parkinson's disease.
I think that for all of us, having a resilient brain, and a lot of these are about that, making your brain more resilient, increasing the network, increasing cognitive reserve, and not damaging it, makes you less likely to develop one of these diseases. It doesn't make you less likely to have the pathological changes, but just going on from what we were talking about before, it makes you less likely to have the symptoms. And we all have this reserve in our brain that we can have a degree of pathology before we have the symptoms. And the more education we have, the more reserve we have in our brain.
Thanks. So here's a question. So the biomarker neurofilament light, or NFL, has been a very hot topic in Huntington's research. You probably have heard about it. So this person asked, are there data available around NFL and dementia?
Yes, people with dementia also have a high NFL. It's a universal indicator of neurodegeneration.
And so here's a specific question about what kind of sports people should practice. Is there a difference in what they do? Should they be doing endurance versus strength or high impact? Is there a difference in what people do?
I don't think there is evidence particularly that there's a difference. I think people should do what they like doing because they might continue to do it. And if they hate doing it, they're pretty much likely to stop.
Yeah. I have a similar question. So you had mentioned for kind of cognitive stimulation, things like Sudoku aren't what you should be doing. Do you have any recommendations of what you should be doing to kind of give yourself a mental exercise?
I think doing Sudoku is fine. It's just not enough. I think the thing is variety. Okay. So, you know, whatever you do, you should do. If you cook some things and cook differently and see different visual arts or read different things and talk to different people and have different challenges, that, you know, anything, but have a variety, different things that use different bits of your brain will keep it healthy. So if you do Sudoku, you'll get really good at Sudoku, but that might not be enough. And so do a bit more, do a bit more varied things that keep you thinking.
That's fantastic. I think that's a good question to go out on, right? To keep ourselves mentally stimulated, to try different things and be as diverse as possible. So I'm going to wrap it up there. We cleared our question stack, I think, for the first time ever, but I will still send those over to you, Jill, if you want to follow up with anyone. I want to end by, again, thanking our sponsor for this webinar, Ionis Pharmaceutical, as well as everyone who donates to the HDF to support the research that we fund. And of course, all of you for tuning in. And last, but certainly not least, Jill, thank you so much for sharing your work with us today. It's fascinating to hear the parallels from different fields and how we can apply that to Huntington's disease. So thank you so much for joining us.
And thank you for inviting me. It's been such a pleasure.
Thanks. Our next webinar is Thursday, April 24th. We are going to be joined by Dr. Gabby Balmus and Dr. Zach McLean, who will be sharing their work on genetic modifiers and how we can potentially target them to stop Huntington's disease. So registration for that webinar is now open. You can head over to the HDF website so you can get it on your calendar and you don't forget. Thank you all so much for joining us, and I hope to see you next month.